Hey guys, Dr. Shah here, and in this video, we'll talk about diagnosis and examination. But before we do that, let's quickly talk about inflammation, since it's the basis of pretty much every periodontal condition. The clinical signs of inflammation are classic indicators of the body's immune response to injury or infection. These signs include heat due to increased blood flow to the affected area, redness caused by vasodilation and increased vascular permeability, swelling resulting from fluid accumulation in the tissues, pain due to the release of inflammatory mediators that stimulate nerve endings, and loss of function, which may occur as a result of pain, swelling, or tissue damage. I also want to quickly touch on cellular adaptation, which is just a fancy way of discussing how cells respond to various physiological and pathological stimuli. Common adaptive responses include hypertrophy, hyperplasia, and atrophy. Hypertrophy refers to the enlargement of individual cells, which leads to an overall increase in the size of the affected tissue or organ. Hyperplasia is characterized by an increase in the number of cells, also resulting in tissue enlargement, but through cellular multiplication rather than cell growth. Finally, atrophy involves a decrease in the size and function of cells, leading to a reduction in the overall size and activity of the tissue or organ. All right. Now let's talk about embrasure spaces, since they set the stage perfectly for our next topic. Embrasure spaces can also be referred to as interdental gingival height, and it just describes the space between adjacent teeth that is normally filled by the interdental papilla. We have 4 classifications here. The first is normal, and to describe what this is, we'll need some reference lines: the facial CEJ, the interproximal CEJ, and the contact point between the teeth. So in a normal situation, the papilla completely fills the interdental space, indicating healthy gingival architecture. Next, we have class 1, where the tip of the papilla is located below the tooth-to-tooth contact point, but remains above the cemento-enamel junction. Class 2 is next, where the tip of the papilla is at or below the interdental CEJ, though the facial tissue remains above the CEJ. And finally, class 3, where there's a complete loss of the interdental papilla and the tissue is positioned at or below the facial CEJ. Now, based on the classification of the embrasure space, we can recommend different hygiene tools to our patients: floss for normal or class 1 spaces, interproximal brushes for class 2 spaces, and end-tuft brushes for more open embrasures. Okay, with that out of the way, we can now turn our attention to one of the most important diagnostic examination tools we have in dental hygiene. It's none other than clinical attachment loss. We can calculate this during our periodontal examination. We'll first need the probing depth, which is just the distance from the gingival margin to the base of the pocket. The second measurement is from the gingival margin to the cemento-enamel junction. Note that this number is positive if the gingival margin is below the CEJ, and it's negative if the gingival margin is above the CEJ. Now, in the case of this image here, our gingival margin is below the CEJ, which indicates recession of about 2 millimeters. You add these two numbers together and you get the almighty clinical attachment loss, which is essentially measuring the distance from the cemento-enamel junction to the base of the pocket. Cal is the most important assessment tool we have because it considers both pocket depth and gingival recession. So in this example, we had a probing depth of 4 millimeters, a gingival margin to CEJ distance of 2 millimeters, which gives us a clinical attachment loss of 6 millimeters. Easy peasy. Now we're going to go over the 3 states of the periodontium. The first is periodontal health. Periodontal health is when the gingiva and the supporting tooth structures are healthy. In periodontal health, there's no inflammation, there's no clinical attachment loss, and there's no underlying bone loss either. So you should expect to have probing depths ranging from 1 to 3 millimeters in a patient with periodontal health. The next is gingivitis. Gingivitis is when there's inflammation but no clinical attachment loss or bone loss. So gingivitis starts when the accumulation of bacteria on the tooth surface forms subgingival plaque, which presents a microbial challenge to the host. If this plaque is left for too long and not adequately removed through oral hygiene, the inflammatory response in the host is upregulated by the immune system. Now, an important thing you'll want to remember about gingivitis is that it's reversible, since we haven't had any clinical attachment loss just yet. The last state is periodontitis. And periodontitis is when there is inflammation, there is measurable clinical attachment loss, and there is underlying bone destruction. So unlike gingivitis, periodontitis is irreversible. Once that bone is gone, it's almost impossible to get it back to where it once was. We can, however, treat the area and return it to a state of periodontal health. Now, you may be wondering, what other tools do we have at our disposal to diagnose clinical attachment loss or see this bone loss that I'm talking about? Well, we can also look at radiographic bone loss, or RBL for short. This is actually part of staging periodontitis, which I'll have a whole video dedicated to later on. So, how do we accurately determine if bone loss has occurred? Well, bite wing radiographs are the gold standard to detect bone loss, more than PAs because it's easier to assess changes in bone height with these ones. Horizontal bite wings are effective in showing the general bone around teeth, making them suitable for early stages of periodontal disease. However, vertical bite wings are king. They provide a more detailed look at the crestal bone level, making them the required standard in cases with severe bone loss. You may also run into a few questions about bony defects on a radiograph on your exam. So here's a list of the most common. The first one is horizontal bone loss, and this is uniform, even bone loss around the teeth, and it's parallel to the CEJ. So a big tip to keep in mind when assessing bone loss is comparing it to the CEJs of the teeth. If it's parallel and uniform, it follows that CEJ, like this radiograph here. So this is horizontal bone loss. The next type is vertical bone loss. This is angular in nature, and it leads to this sloping defect. Now, I want you to look at the CEJ of tooth number 20 and the CEJ of tooth number 19 and imagine a line connecting the two. You should easily see that it's nowhere near parallel to the vertical angle bone loss here. In fact, it's more perpendicular than anything. This is common in vertical bone loss and something you should get used to seeing. You may also run into crater form defects, and you can think of this like a bowl. It's bowl-shaped. So the buccal and lingual walls are intact, but in the middle, along the mid-crestal area, it's completely cratered out like the bottom of a bowl. These tend to have this weird-looking appearance on the radiograph. So notice that this defect is not completely radiolucent, right? It's not completely blacked out. There's some radial opacity there, and that's due to the intact buccal and lingual walls. So they have a little bit of gray to it, and that's how you can differentiate these defects from vertical bone loss defects. Lastly, we have the circumferential defect. This is most clearly seen around implants with peri-implantitis. So chances are, if you have a question regarding peri-implantitis, it may have a circumferential defect. The definition is that it's a vertical defect that completely surrounds the tooth or the base of the implant, hence the name circumferential, or a 360-degree defect. Now, you may be wondering, what conditions lead to these different bony defects? Why do we get a horizontal bone loss in one instance and vertical in the next? Well, it really all depends on the pathway of inflammation. Let's consider horizontal bone loss first. This pattern of bone loss occurs along the path of least resistance. In this case, inflammation spreads from the gingival connective tissue directly into the alveolar bone, resulting in bone resorption that runs parallel to the CEJ. The periodontal ligament is affected secondarily. In contrast, vertical or angular bone loss occurs when inflammation travels along the periodontal ligament space before involving the adjacent alveolar bone. This gives rise to an oblique or angular bone defect. Now, depending on the type of bone loss we get, we also have two different ways we can describe a periodontal pocket. In a suprabony pocket, the base of the sulcus is located coronal or above the level of the alveolar bone. This type of pocket is typically associated with horizontal bone loss, where the bone is lost in a uniform leveled manner. In contrast, an infrabony pocket has the base of the sulcus positioned apical or below the crest of the alveolar bone. This type of pocket is linked with vertical bone loss, where the bone is lost in an uneven angular pattern, which often creates a deep osseous defect. Now that we've gone over periodontal disease, let's talk about how to diagnose gingivitis and periodontitis. Now, we're going to go through diagnosis in a more detailed video later on, so I'm going to keep it brief here. A diagnosis of gingivitis consists of probing depths less than or equal to 3 millimeters, bleeding on probing in at least 10% of the sites, and sometimes pain, redness, and swelling because of the inflammation, of course. A diagnosis of periodontitis consists of probing depths greater than 3 millimeters, which just means there's clinical attachment loss. So there's cal of at least 1 millimeter, and there's radiographic evidence of bone loss as well. We need that. Now, a key thing to always remember amidst your examination is that an increase in probing depth is an indicator of periodontal disease progression in those sites. So definitely make sure to remember that. We could also have the diagnosis of peri-implantitis. The high-yield point here is that peri-implantitis is similar to periodontitis in that it has similar microorganisms that are responsible for the disease, those being gram-negative anaerobes. One difference, however, is that probing depths around an implant can be much higher than a tooth, so that 3 mm threshold won't be good here. You'll want to instead look for probing depths greater than or equal to 6 mm and the presence of radiographic bone loss around the threads greater than or equal to 3 mm. Now, the management of peri-implantitis varies based on how severe it is. So in mild forms, we could get away with just non-surgical interventions, such as scaling and using chlorhexidine and systemic antibiotics. However, the most definitive approach and the gold standard for treating peri-implantitis is surgical therapy, specifically open flap debridement, which involves the removal of granulation tissue and calculus that has built up on the threads, and then pocket reduction, which is just decreasing the soft tissue so that the probing depths are less and that the area is more cleansable. Sometimes it's even required to smooth out the body of the implant to make it more resistant to plaque accumulation. There's also several prognostic factors for periodontitis that we should be aware of. A younger patient who has the same periodontal diagnosis as an older patient, for example, has a worse prognosis because the rate of progression of disease is higher in the younger patient because, well, they got the diagnosis earlier. Simple as that. The presence of biofilm is another one, especially when there are heavy deposits of plaque. Lastly, poor oral hygiene, or lack thereof. This one's obvious because it leads to more biofilm and plaque. When plaque is not removed, it can turn into calculus and facilitate the inflammatory response, which can contribute to further destruction of supporting periodontal structures. Now, on that note, I want to quickly touch on calculus itself, since you're likely to come across some questions regarding it on your exam. So over time, if plaque is not removed, it can harden and become calculus. So calculus is just mineralized dental plaque. If it's above the gums, it's supragingival calculus, which typically presents as a white or yellow in color plaque, while subgingival calculus presents as brown or black in color. You'll definitely want to remember that characteristic and the colors. Now let's talk about tooth mobility, which is classified into 3 categories based on the degree of movement. Class 1 involves horizontal movements of up to 1 mm. For all intents and purposes, this is considered physiological. Class 2 is characterized by horizontal movements between 1 and 2 mm. Class 2 mobility should definitely clue you in to the fact that something bad is happening with the tooth or periodontium. And finally, we have Class 3, which indicates horizontal movements greater than 2 mm and or the presence of vertical displacement, where the tooth can be depressed into the socket. And while on the topic of tooth mobility, another high-yield point to know is that the mandibular canine is a tooth that is least likely to be lost due to periodontitis. This is because the mandibular canine has the longest root in the mouth, making it the most resistant to bone loss. In the same light, the maxillary second molar is the most likely to be lost due to periodontitis. Its posterior position and complex anatomy make it very difficult for patients to adequately clean it, which leads to early furcation exposure and poor accessibility for plaque control, all of which make it more susceptible to advanced attachment and bone loss. And speaking of furcations, I want to quickly put the spotlight on an important tool in our armamentarium, the almighty Nabers Probe. So as a refresher, furcation involvement occurs when periodontal disease causes bone loss between the roots of the tooth, exposing the furcation area. The unique design of the Nabers Probe allows it to curve into the furcation area and measure the depth. Furcation involvements can be further classified based on their clinical presentation and extent. Class 1 refers to the earliest stage of furcation involvement, where the probe penetrates the concavity of the furcation no more than a millimeter. Class 2 occurs when the probe enters the furcation more than a millimeter, but it doesn't pass completely through to the other side, so this indicates partial bone loss within the furcation. Class 3 represents complete bone loss in the furcation area. In this stage, the probe can pass entirely through the furcation. However, the opening remains covered by gingival tissue and won't be clinically visible. Class 4 furcation involvement is similar to Class 3, but the key difference is that the furcation is clinically visible due to gingival recession exposing the opening. Alright guys, we're almost done. Now I want to quickly talk about a condition that often exacerbates perio issues. It's none other than diabetes mellitus. Diabetes significantly impacts both periodontitis and peri-implantitis by exacerbating their progression and complicating their management. How does it exactly do that? Well, it all begins with elevated blood glucose levels in the bloodstream, which leads to an increase in inflammatory cytokines. These cytokines enhance tissue breakdown and worsen the progression of periodontitis and peri-implantitis. Additionally, diabetes can alter the oral microbiome, promoting the growth of pathogenic bacteria that contribute to infection and inflammation. The disease also heightens oxidative stress, which further damages tissue and impairs healing, making it more difficult to control these infections. Another high-yield point to remember is that diabetes inhibits osteoblastic activity, which reduces bone formation and impairs the body's ability to regenerate bone around affected teeth or implants. Overall, poorly controlled diabetes not only accelerates the progression of periodontitis and peri-implantitis, but it also complicates their treatment and healing, requiring careful management to mitigate these effects. And with that, we are done, guys. Now let's reinforce everything we just learned with some practice problems. Okay, question number 1. Each of the following are indicators of periodontitis except one. Which one is the exception? So pause the video if you need some time to get your answer. But the answer is D, presence of calculus. So if you have calculus, that's a risk factor for periodontitis, but it's not an indicator of periodontitis. Indicators of periodontitis include gingival inflammation, clinical attachment loss of at least 1 millimeter, sulcular depths greater than 4 millimeters, and alveolar bone loss. So I hope you got that one right. Okay, so here's another one. We have a male 65-year-old patient with a chief complaint of receding gums. He's a current smoker, he hasn't been to the dentist in over 5 years, his oral hygiene appears inconsistent, and he admits to only brushing once a day. Current findings indicate generalized gingival inflammation and signs of calculus buildup. So the question is asking, what's the clinical attachment loss of tooth number 4? And it gives us a probing depth of 7 millimeters on tooth number 4 and a gingival margin to cemento-enamel junction distance of 3 millimeters. Go ahead, pause the video, and think this one through, but it should be pretty straightforward. And the answer is, of course, C, 10 millimeters. So clinical attachment loss is calculated by adding the probing depth to the gingival margin to CEJ distance. So 7 plus 3 is 10, which is the clinical attachment loss on this tooth. Now, as a reminder, guys, the gingival margin to CEJ distance may be a negative number on your exam. If you have that, you still just add the numbers together to get your answer. Simple as that. All right, next question. We have a female patient who's 72 years old with a chief complaint of, my tooth bleeds when I floss. She is diabetic with an HbA1c of 7.5%. She's taking metformin and lisinopril, and her current findings include localized recession of tooth number 19 with generalized wear facets and mild xerostomia. Tooth number 19 has a probing depth of 2 millimeters, and it has 2 millimeters of recession as well. So, what is the most likely periodontal diagnosis here? Go ahead and pause the video. And the answer is A, localized gingivitis with recession of number 19. Because the recession is only on tooth number 19, the disease is localized to just that tooth. We don't have any other information about the rest of the mouth, and because the probing depth is less than 4 millimeters, we can assume that gingivitis is the most appropriate diagnosis. And with that, we are done. As always, guys, here's a quick list of important topics that I discussed in this video. Thanks for watching, and see you next time.